have daycare services. Thank you, Nilanjana. It's my privilege also to introduce Dr. Sridhar Vaitheswaran, a psychiatrist profession, an assistant director and consultant at Dementia Care in SCARF, DemCares, Schizophrenia Research Foundation, India, SCARF, Chennai, India. A clinician who runs a clinic for the elderly with mental health problems and those with dementia in SCARF Hospital, Chennai. His interests also include applied research in dementia care in low and middle income countries. Presently working on implementive cognitive stimulation therapy, CST, for dementia in India, supported by Global Alliance for Chronic Diseases and funded by Indian Council of Medical Research. It also funds implementing psychosocial interventions for dementia in rural communities in India. START, that is strategies for relatives. Adapting interventions for caregivers of persons with dementia in India, and in partnership with Imperial College London, testing the feasibility of using hybrid phase humanoid robot in engaging persons with dementia in India, and that which is funded by Department of Science and Technology, using Android-based applications for improving diagnosis for dementia in the community. Welcome, Dr. Sridhar. We would love to hear some more exciting things that you're working on, and we would be delighted to learn more from you. Welcome.
Thank you very much for that kind introduction, madam, and thanks very much for having me here in this forum. I think it's very important what everyone is doing, and it's really exciting to see the kind of work that we are doing in India. And congratulations to both the previous speakers. You've done a wonderful job, and it's still continuing to do that. And I think we are setting standards for future care for dementia in India, and it's fantastic to know that. So I'll start by sharing my presentation. This is a very small study that we carried out in our service at the beginning of the pandemic, sometime in April, May, and June. So we did this the beginning period, and we wanted to look at what our caregivers of people with dementia were experiencing and what they needed during the pandemic. Because when the pandemic started, as many of both the previous speakers have alluded to, there were no guidelines to support what we should be doing at these times. So we wanted to explore that, and we know that pandemic has an impact on dementia, on people with dementia, and because we know that isolation and quarantine causes a lot of distress, even amongst those without dementia. So, and people with dementia are particularly more vulnerable to developing COVID-19, and also to the impact that isolation and quarantine may have during this time. And we also know that people with dementia will generally, even otherwise, even in the absence of the pandemic, have very limited access to healthcare services. And this was just accentuated during the pandemic. This we have enough evidence for. And we all know about this particular graph, that numbers of people with dementia is growing, and that's a cause for concern for many of us. And we also know that many people with dementia do not have adequate care and support. So when we looked at how to support our caregivers and persons with dementia during this pandemic, we couldn't find any specific published information on this topic. So we wanted to go and find out what exactly happens during this time. So our aim of this particular study was to describe the experiences and needs of caregivers of persons with dementia during this pandemic and lockdown. I mean, those were the periods where we had very strict lockdowns across the country, and to develop a model to understand their experience and needs. Now, the reason we think this is important is, of course, we are going through a pandemic, and hopefully by next year, we should have a vaccine, and we should probably start seeing much less of an impact of this particular pandemic. But when you look at the growing pressure on our ecosystem and looking at the risk for future pandemics and disasters, I think it's going to be something which we are going to experience, unfortunately, more often. So we should be prepared for such potential issues in the future. So Our participants were caregivers of people with dementia and who were seen in our outpatient department within the previous 6 months. So we did a purposive sampling because we just wanted to take a select, and I'll explain that in a minute. And our inclusion criteria were family members who are providing care for and living with the person with dementia. They can't be living remotely and supervising the person with dementia. So somebody who is living with the person with dementia, who is an adult, and the person must have a confirmed clinical diagnosis of dementia. So this is scarce for those who haven't visited us. So our institutional ethics committee approved the study, and an important modification to how we conducted the study was obtaining voluntary consent through telephone. Given the circumstances and given the time-sensitive nature of this particular study, our ethics committee approved that we could obtain informed consent by telephone when we recorded those consent procedures. So the consultant psychiatrists, the 3 consultant psychiatrists working in my team, and all of us conducted the telephonic semi-structured interviews, and we knew our patients and the caregivers. We are familiar with them, and the interviews were conducted in Tamil and English, and all the translations were translated. All the interviews were translated and transcribed to English, and the 3 of us independently coded all the transcriptions, and then we completed a thematic analysis. So this is just to give you an overview of our patient selection or participant selection process. So in the previous 6 months prior to the lockdown till the end of February, we had about 153 persons with dementia and their families, of whom we were able to contact 88 caregivers by telephone during the lockdown, and of whom 56 of the caregivers agreed to participate in this interview. And we stopped at 31 caregivers because we reached what we call as data saturation in the qualitative study, because we weren't getting any more new information beyond that point. So we stopped at 31. And again, this was a time-sensitive process. We wanted this information out very quickly. And this is just to briefly describe the characteristics of our participants. Most of the caregivers, the mean age was in the 50s. Many of them, and again, when we talked about purposive sampling, I wanted a mixture of both, an equal number of, at least an equal number of men and women of caregivers. So we had about 16 women as caregivers and 15 men as caregivers. And just to give you other descriptions here, and many of them were from the middle socioeconomic status. Again, majority of them of our people with dementia were women, and we, even though we try to limit it to about 54% by a purposive sampling method, and majority of our participants were mild to moderate persons with dementia. So our results, we could identify the experiences of caregivers, and then we also identified their needs. So we could classify this under 2 broad headings under experiences and needs. And within the experiences, there were issues that were directly related to their caregiving responsibility. That was about looking after someone with dementia and the problems that they faced in looking after someone with dementia. And then the issues that weren't directly related to caregiving, which was shared across anyone living in the community. So issues like getting their food, going out to get their exercise and things like that, which was common to everyone. And then, of course, there were needs which were immediate needs. They had lots of things that needed to be attended immediately. And then, of course, they were also worried about what was going to happen in the longer term once the pandemic is over, which were kind of very similar to what we were facing before the pandemic. So starting to identify themes that were emerging when we looked at issues that were directly related to caregiving role during the pandemic. The first important concern that many caregivers had was about protecting the person with dementia from the infection. So many of them were worried about the person with dementia refusing to wear a mask or not following hand hygiene measures or restricting them within the homes. So which was a major problem for many caregivers. They were struggling with that. And of course, many of them also were concerned, if my relative were to become infected, how will I manage them? Should I hospitalize them? And how will they manage this person with dementia in the hospital? They have a lot of special needs, and without me, they will be very confused. So how will that work out? So a lot of families had concerns about that. And also dealing with the daily routines and activities. And again, this experience is universal from what we heard so far, both from Bangalore and also from Kolkata. And we know that day centers stopped working. And I'm glad that the Kolkata day centers started working again. And because the day centers have stopped, many of the activities had to stop. And in addition, when they tried to do activities at home, they couldn't get the material. This particular gentleman who was looking after his wife with dementia couldn't source papers, couldn't source coloring material because many of the shops were closed, and they couldn't get delivered this on Amazon as well because the home delivery was locked during the lockdown period. It wasn't allowed. So there were lots of issues, practical issues the families faced. And again, the other important concern was attending to the health and well-being of the person with dementia. So there was a gentleman with dementia who had a severe eczema in his leg, and they couldn't go and see a skin specialist for this. And that this was the initial time during the lockdown when the remote clinics, teleclinics weren't working as efficiently. People were still trying to understand how to provide these services. So that was a major concern for many of the families. And again, an important problem during that time was people weren't allowed to go out for walks, even if they wore a mask or gloves and accompanied just with one person. In many places, the public parks were closed. At least in Chennai, the parks were closed, and the police weren't allowing people to step out of their homes. So this was a major problem for many families, that people were not getting enough exercise in their daily routine. And an important problem was managing behavioral problems during this time. So because the daycare centers were closed and because the person was restricted within the home environment, they were actually getting very restless and their behavior was getting worse. And on top of that, when family members were trying to work from home, this was becoming a problem because this particular gentleman, the son, was trying to work in his room using his computer, and this gentleman with very advanced dementia would come on the door and start banging on it because the door was closed. They didn't like closed doors. So that was a major problem for this particular family. So going on to the next major theme was looking at issues that was shared by everyone in the community. So all of us had these problems during this time, and caregivers with who were looking after those with dementia also had these problems, but this accentuated their caregiving. On top of providing care within these restricted circumstances, they also had to deal with these mundane and routine issues. So managing daily household chores, because the help at home was stopped. People couldn't come and help this elderly couple staying by themselves. And this particular lady was unable to look after the husband who had dementia and also attend to the house. So that was a major problem. And there were disruption to work and financial concerns because many people lost jobs. This was from an auto driver who had to stop working and he didn't have much income. He was looking after his mother who had dementia, and there were lots of problems within that family. And again, looking at the caregiver's own health and well-being. So this was another lady who had eye problems and couldn't go and see the doctor, and she couldn't lift her mother who had dementia. So she had to lift her up, and she was worried about her eye issues, and which she has been advised against lifting weights, and she couldn't go and see the doctor for reviews as well. So she had lots of concerns during this time. And of course, as before, the worries about what will happen if I am quarantined, if I am infected, how will my relative with dementia manage without me? So that was a concern. And the biggest concern that almost everyone shared was stigma about being infected with COVID-19. I don't know about the other cities in India, but in Chennai, there were notices being stuck in front of the families' homes, and there were barricades being put up in front of their homes. And this was a big this made people shameful of being infected with COVID, and everybody actually was very afraid. So if my neighbors were to know that someone in my family is infected with COVID, how will I get any help at all in the future? And will people shun my family? So there were lots of concerns. In addition to dealing with looking after someone with dementia, they also had to deal with all these issues. So just to give a model about what was going on. So there were issues which the caregivers faced that directly related to their caregiving responsibility. And then there were issues that did not relate to caregiving responsibility, which everyone faced. And these two led to specific needs for the caregivers. And so the model had to include how we provide support to meet those needs. So starting with immediate needs. So looking at engaging a person with dementia at home, the many families have this major need. They had to engage the person so that the person doesn't get restless, agitated, or have behavioral problems. And again, looking at supporting the person with dementia at home by providing enough assistance for their physical needs, for their medical needs. There were lots of requirements, the need to consult with specialists, access to medicines with dementia. This was a major problem. Many of the pharmacies didn't have enough supplies of specific medicines used for dementia, and they needed paper prescriptions, which was a problem for many families to source these medicines. So there were lots of policy-related issues which also came up during this time. And when particularly talking about implementation of policies, I'll come to two specific examples in a minute, but the policies that were enforced nationwide to control the spread of the pandemic had a very direct negative impact on caregivers and persons with dementia. So this is something which we need to address as a national organization. And then looking at long-term needs, there were kind of usual ones that we already are aware of, talking about trained home care support, caregiver training, and the need for respite services, and increased awareness within the society. So this is a kind of particular case which I would let you read this in a minute. We can go over this particular quote. So we had a gentleman with very advanced dementia who was restricted within the home, and the family was keen to take this person to their family home about 200 kilometers away from Chennai. This was in a village, and they had their own garden, and the person with dementia could walk out very freely. But unfortunately, when they asked for permission for travel, this was declined. The reason was the authorities did not consider dementia as an emergency medical problem or a health problem for that matter. Even with the fact that I had written a letter to support this particular move, because this gentleman's behavior was getting really worse, and there was a risk that he was going to harm himself seriously or the caregivers in the family members quite seriously. So this was a major concern, but unfortunately, the authorities did not allow for him to travel during that time. And then there was another gentleman with, again, a very advanced dementia. He used to have a problem with scratching. He would scratch himself all over the body. And we actually avoided this by giving him a soft toy. So he used to have a soft toy in his hands all the time, and this actually worked very well for him. But unfortunately, over the 3-month period, the toy had worn out, and they actually had to go and purchase a soft toy from a shop, but all the shops were closed, and Amazon or Flipkart didn't allow home delivery during this period. And then he started scratching himself during this time. Of course, we had to innovate and kind of cover the old toy with cloth and things like that, which we tried to improvise, but we really didn't work as well as actually having a new toy for him. So, but how the policies are used and how the policies are implemented in the community is something which we probably need to be advising people about, because the health of people with dementia and the issues that people with dementia go through is not something which is highlighted adequately to the policymakers. So that's something which clearly came out from the experience of our families. So in terms of how to provide support, of course, many families were keen to use video calls and telephone calls, but of course, not all of them were keen to use this. The main issue was about they didn't have the experience, or they were actually quite afraid of using technology. What will happen if I touch some button inadvertently? Something might go wrong, or this might break, and things like that. So many elderly couples had problems with that. And of course, many families from low socioeconomic status didn't have access to technology. All that they had was a telephone and a simple mobile phone, and that too many families struggled with. And many persons with dementia were unable to participate in a call, particularly those with very advanced dementia or those with severe behavioral problems. And again, when people were living close to healthcare services, they were actually quite okay to walk in. A caregiver could walk in and get a prescription. And some families, very few of them, actually they felt that things were going okay and they didn't need to use technology at this point in time. And of course, the clinic-based in-person visits were continued. We did weekly clinics rather than daily clinics, and then the clinics were very strictly controlled. We had all the procedures to prevent people with infections coming into the hospital, and we had lots of screening procedures and things like that, and all of us wore personal protection and masks. And of course, that created its own set of problems. During the summer months, it was so hard sitting with the PPE in a room for few hours continuously. And also with hearing, many people with dementia also had hearing impairment, and they really had difficulty hearing what we were speaking with the masks on. So that there were kind of lots of issues. And of course, we need to provide more services post-pandemic, and I'm sure the ARDSI will play a very important role in this process. So concluding, caregivers face special challenges in looking after someone with dementia during the pandemic. And of course, they must balance these with the challenges shared with everyone else during these times. So the caregivers need special focus, special support. And supporting these times requires a pragmatic, multi-layered approach. We can't just say we'll rely on technology and technology is a solution. We actually have to combine technology with other practical measures. And of course, a lot of changes in policies, frameworks, use of technology and better access to health are necessary in the longer term. And much work is needed to support caregivers and also to ensure that we are prepared for any future disasters. Unfortunately, as we talked about earlier, this is not this is not the first time we are going to see a pandemic or a disaster. This is going to happen, unfortunately, more often in the coming decades. So we better be prepared for that. And those are limitations. This study was conducted in one service in India, and we only could contact those who had a telephone access, who responded to our telephone calls. So we can't really generalize all the findings. And of course, we have to look at how best to support the caregivers and provide interventions. We are already working on the next phase of this study is currently on. We are collecting data and providing remote services, clinics, and we are planning to provide virtual cognitive stimulation therapy. In fact, in the first week of October, we are going for an ethics approval for that particular study. So there's lots of things which we can potentially do in the future. Now, for those who are familiar with Chennai, this is the iconic Vivekananda house where Saint Vivekananda came to Chennai and stayed in this place a long time ago. And I caught this while I was running. This is by the beach, by the way, in Chennai, a nice rainbow there. And I thought there was a message there for all of us that it's not that bleak and we could do a lot more for our clients. So this is my team, without whom we can't do much of the work that we are doing. And I'm really grateful for all the caregivers who participate